three times ago. Otherwise, VMR is not launched. So welcome to another VMR. It's another special one. I'm here together with Ravi and Austin. My name is Samy. I'm one of the CP Solvers team member and a huge fan since a long time. And I think 1 year ago, I also became a team member. And yeah, we have a beautiful crowd here. Thank you all so much for joining us today. I'm a physician since 2 months now, and I'm very busy with internship, but if I'm able to join, I always join. And yeah, I have the pleasure of discussing a case together with Ravi, and I know it will be a tough and interesting one and a very fruitful one for all of us to learn, because Austin's cases are, I can speak from experience for following VMR for quite a time. They are always a roller coaster, and we all learn so much from him. So yeah, thank you in advance, Austin, and Mike to you, Ravi.
Oh, thank you, Samy. I'm absolutely stoked to be once again discussing a case with you, and congratulations on becoming a physician and seeing the fruits of your labor coming to fruition. So wonderful, wonderful. I'm just so excited. If I have to discuss, we've had some really wild cases, and I've been very happy to be at your side and discuss cases, and definitely you've come up with some wonderful theories with these cases. So hopefully once again we'll be able to tackle this case. And always remember, it's the journey, not the destination. So I'm really happy today that Austin has prepared a case and is coming to us next week. Actually, Austin will be co-facilitating with Alec for Tuesday CPS, so stay tuned for that. But today's brought a POCUS VMR case for us, so it'll be great to have another session of point-of-care ultrasound with a case. So I'll hand the mic over to Austin.
Well, thanks so much. Excited to share this case with you guys. I'm just going to share my screen. Let's see. Can you see my screen?
Yes.
Perfect.
I'll change the view to the other. Yeah. Yep. There you go.
Perfect. All right. So I have it sort of divided up already into slides that will say, I think this is the time for discussion. So I'll just kind of go through each slide, and then when we hit that slide, you guys will take it away and show your magic like you always do. So here we go. So this is a woman I saw in clinic some time ago, but she's 50 years old, and she came in with abdominal pain. I guess that's the only slide. Would you want to stop there, or want us to give more information?
I think we actually have the whole hour. What do you think, Samy? Like, you see this patient, 50 years old, in your clinic. What would you think at this point?
Yeah, I don't know. Abdominal pain is such a broad, it has so many differentials, but if quick type 1 thinking, is there pathology in the abdomen or not in the abdomen? For example, coronary ischemia, for example, that can also cause abdominal pain. But otherwise, think of all the organs that are in the abdomen, and also ask where is it located. You still got to be cautious, because it's very stacked in there, and you can have projected pain and referred pain. So always caution that. But otherwise, ask where is it, how is the type, is it more colicky or more constant, what are any associated symptoms, any risk factors, ask about the severity, what alleviates, what worsens the pain, stuff like that. But yeah, I would start with that. And if we're thinking POCUS, we're definitely going to get sonography of the abdomen. Yeah.
Oh, I just love your strategy there for further asking questions regarding the pain, severity, and so on. But two things I kind of would also add to your wonderful discussion there is this actually an abdominal pain, or is this just part of a complex presentation that's outside the domain of the abdomen? So various things like diabetic ketoacidosis can accompany abdominal pain. And then I would also wonder about emergency diagnosis. So that's where the point-of-care ultrasound will come in helpful if we are dealing with a life-threatening process. But back to you, Austin. I'm kind of going to be frugal here with my thought process until you give us more information.
Sure. No, great discussion so far. And so here's some more information. So she reported 3 weeks of what she described as inflammation in the stomach, as well as like a sensation that there was a ball in her abdomen. The pain was intermittent. It was mostly left-sided and radiating to her back. 2 days prior to her presentation, she had sort of a newer pain, which was very severe. And she described it as her intestines twisting, and she hadn't noted any real association with food. So on her review of systems, she had no nausea or vomiting. She was taking PO. She had no sort of constitutional symptoms. She had noticed some constipation that was new for her, but no dark or bloody stools. And the last time she had a bowel movement was a small one earlier that morning. She does have a history of GERD, but she didn't feel like her current symptoms were at all similar to what she usually experiences when she has GERD. She had no urinary symptoms, and then she was not currently sexually active. She had no gynecologic symptoms, and she had entered menopause 6 years prior. So what do you guys think so far?
You can start with this, Samy. I'll add on to your discussion after.
All right, sounds good. Austin, do you mind going back to the slide, to the first slide? So the pain seems to be in the epigastrium because the patient says like inflammation in the stomach, and she will most likely point like subxiphoidal. And so I would maybe translate that into epigastric discomfort or pain. The sensation of a ball in her abdomen, I would still ask, where does she feel that ball? Is it more in the upper or in the lower abdomen? And now we have a little bit more characterization of the pain. It is intermittent. So what causes intermittent pain? Whenever I think of intermittent pain, I think of like something as obstructing and smooth muscle contracting, for example, colicky pain, for example, if you have a gallstone, a kidney stone, or also if you have like a small bowel obstruction or just bowel obstruction, that could also like be intermittent in nature. Otherwise, also vascular entrapment syndromes. We had a lot of cases of all these rarer vascular syndromes. So also thinking of that. The left side makes me more think about like the spleen, organs on the left side, the colon, and also the kidneys especially. And the thing that it radiates to the back makes me think about the pancreas, also about the kidneys, but also important to remember that also gallstones can radiate to the back, especially if the concrement is in the ductus choledocus. And yeah, that's how I remember it. Yeah. Otherwise, 2 days prior to the presentation, new severe pain is described as intestines twisting. We always think about, if acute abdominal pain, we think about the pneumonic, vascular, inflammatory perforation or obstruction. Vascular definitely could be at play. She doesn't seem to have the obvious risk factors for intestinal and mesenteric ischemia, for example. Any sort of inflammation is still fair game with her. As our beloved neurologist, Aaron Berkowitz, always says, you can have a pen rolling down a table, and when it falls, then you have the symptoms, but something has been brewing in the background. Just because someone has acute pain, it doesn't mean that she can't have appendicitis. Actually, in my last night shift, I had a patient with acute pain that ended up having fulminant appendicitis. Yeah, no association with food. When we think about food association, we think about the digestive organs, what pain gets worse with food, for example, pancreatitis, gallstones, peptic ulcer disease, and also mesenteric ischemia. When there's no association with food, that maybe lowers these differentials, but they're all still very fair game. And yeah, I've talked a lot. I would pass the mic to Ravi.
Oh, no, you definitely generated a whole slew of different hypotheses. And I think everything is fair game. And at this point, it's difficult to just say like, okay, it is this presentation is pathognomonic for this condition, pancreatitis and so on. So I think all the different organ systems that you mentioned, especially the left side, are definitely in play here. What's interesting, I'm just sort of looking back at cases I've had, so experiential learning, using experience to try and come up with some hypothesis. This sort of twisting phenomena, I've had this described to me with a patient that had a volvulus. So volvulus sort of came to mind, which is system one thinking. But the amazing sort of more analytical thinking that you just deployed here, going through all the different organ systems, and then trying to associate some of the key features like food with this and so on, I think was just a great explanation of these accompanying systems. But no nausea, vomiting does make me feel, okay, this is not probably higher up in the GI tract. Maybe in the stomach and small intestine, you would possibly get nausea, vomiting if there's any sort of obstruction that may be at play here. This patient, I don't think has had a bowel movement, no bowel movement there listed, I think, Austin, yeah, or is the patient passing gas as well? Oh, constipation. Okay, so there is constipation there. So a very common presentation like this that I've had is constipation. I do deal with a large patient population with constipation due to maybe medications and so on, and that can cause severe pain, almost similar to an acute abdomen, and pain can radiate to the back and so on. And sometimes you also can get overflowing continence, so diarrhea accompanying constipation. But in this case, this thought isn't valid. We don't see diarrhea here. Some of that upper sort of intestinal inflammation could be attributed to this GERD as well. And then I love the viper mnemonic, and part of that is also the reproductive organs, just making sure there's no dangerous phenomena at play here, like ectopic pregnancy and so on. So at this point, I definitely think imaging is warranted. And I think also the labs, if this is something that is dangerous like bowel ischemia, you'd see a maelstrom of abnormalities in the labs, especially elevated lactate. So that's something I would want to also obtain. So I think getting the exam, it would be very helpful to see if this abdomen distended and so on, where the pain is, any rebound tenderness and so on. Looking at the vital signs, if there's any impending indication of, say, patient having shock, blood pressure's low, tachycardia, fever, and so on. And then I think third, getting the imaging is also warranted at this point. Any other ideas, Samy, before I hand the mic back to Austin?
No, I love these thoughts. Volvo seems like a good explanation. It could be like intermittent, and also it could explain the feeling of having the gut twisted, and also with the constipation that is new. So we should definitely think about a mechanical obstruction and also in the GI tract.
All right, back to you, Austin.
All right, yeah, amazing discussion so far. So I'll just give you some more information about her history. So she has a past medical history of obesity with a BMI of 30. GERD, as I mentioned. She has hepatic steatosis without fibrosis, and that was confirmed on a liver biopsy. She has hyperlipidemia, and the only surgery that she's had in the past was a tubal ligation, no prior C-sections. And then in her family, she has a family history of uterine cancer, both her mom and her sister at very young ages, but no other cancer history. And I actually previously sent her to a geneticist to sort of get genetic testing, and they did testing, and it had returned negative. Socially, she's from Latin America originally. She's been in the United States for many years. Hasn't traveled recently, works in construction, and then she lives at home with her children and her grandchildren. She takes no regular medications. And so I guess any changes or thoughts after this additional information?
What do you think, Samy? Does this move the needle for us at all? Or are we still holding steadfast in our initial thoughts?
I don't know. I'm somehow still in the same position. Her being from Latin America, I mean, it could be signal, it could be noise. A lot of people come from different places, and you always have to keep in mind that just because someone is from South America, for example, there is an increased risk of tuberculosis and histoplasmosis, stuff like that. But yeah, that was my type 1 thinking, and also her having worked in construction or working in construction also exposes her to different pathogens or also inhalations that could maybe lead to certain manifestations. But abdominal pain would be an odd one, except for peritoneal tuberculosis. So yeah, I don't know. It didn't move the needle too much for me.
Yeah, I agree. There are some potential detractors there, but I still want to stay in our lane and move forward with the labs, imaging, and examination. Well, in the order I would do. examination to see exactly if it can help us narrow our differential to a particular place, although the left side is of interest. The history of malignancy is also very interesting. That could be another potential contributor. It also could be a detractor, but something we need to put on our radar screen. And then, like you mentioned, we had that case of intestinal histoplasmosis, which I've never heard of before, but was very interesting. And then TB, definitely something that's on our radar screen as well. But I'll hand the mic back to Austin to see. Definitely, I think exam is of the order next.
All right. Ask and you shall receive. So here's the her vitals and physical exam. So she's afebrile. Her blood pressure was 95/66, which was her baseline. Her pulse was 86. Her respiratory rate was normal. Sorry, I forgot to include that. And her SpO2 was 97%, which is normal. And then I sort of bolded the most pertinent findings, which she was uncomfortable appearing due to pain, but she had no signs of chronic liver disease or anemia. Her cardiopulmonary exam was normal. She had no lower extreme edema. For her abdominal exam, she actually had a palpable mass in her lower abdomen that extended from her pubic symphysis to her umbilicus, and it was diffusely tender, but there's no rebound or guarding, and the overlying skin itself was normal. And then before we discuss, I guess I'd love to hear thoughts on her exam, and then what would you like to POCUS to try to improve your probabilities as far as a diagnosis based off all this information?
Kind of interesting. What do you think, Samy? Do you want to take a stab at the vital signs physical exam, and then tell us why do you want to POCUS that particular area?
Sure. And Austin, was this tenderness on the right, this mass on the right or on the left side? Do you happen to know?
Sorry, I had a hard time finding my mute. Yeah, it was predominantly on the right side, but it did cross the midline. It was quite large. Okay,
great. Thank you. So the physical exam is mostly unremarkable, except for this uncomfortably appearing woman due to the pain. And we have something that we found, this palpable mass in the lower abdomen that seems to extend from the pubic symphysis to the umbilicus. Yeah, I'm really not sure what to make out of that, especially if it's more on the right side. I was thinking maybe appendicitis, maybe sometimes with Crohn's disease, you can palpate like a mass in the right lower quadrant. Also, malignancy always comes to mind. Also thinking of gynecologic diseases that could maybe manifest that way. Sometimes diverticulitis can manifest on the right side, but that's mostly more in Asians, to my knowledge, or in people of Asian continents. Yeah, the fact that there is diffuse tenderness, yeah, it seems to somehow bother her, and we should definitely check what's going on there. That the overlying skin is normal maybe makes me think less of an infiltrative process, or maybe that hasn't progressed yet. There's no necrosis there. So where I would put my POCUS, definitely get an abdominal ultrasound. I always start like one after the other, check the right upper quadrant, the liver, gallbladder. Is the Morrison pouch? Is there any free fluid? Then go to the left side, go down the aorta and the vena cava, and especially put the probe on that mass and check what's going on there. Although I did this a lot of times when I didn't know what I'm palpating, and I never got an answer because I just didn't know what I saw. But yeah, that would be my approach. Ravi, what would you do?
Absolutely wonderful. Again, I don't have much to add, but again, just drawing back from previous cases that I've had, I had this palpable mass did bring to mind. I had a thin elderly patient that had a lower abdominal mass, and putting your hand on the mass, it was pulsatile, and she was just so thin that it was aortic aneurysm. So I would look for that feature as well. And you probably don't even need an ultrasound to make that diagnosis. But of course, you need to measure the dynamics to determine if it needs surgery or not. But then going through, I would do a layer-based approach, just sort of overlooking the vital signs to this patient. is not in overt distress, although the blood pressure, it's a baseline, so it's not low. So some people may have a blood pressure at that level and it's not concerning. It's not a drop from like 130, 140, which would be a major change. So patient doesn't have a fever, the pulse is not elevated, the pulse ox is fine. In some certain circumstances, you can have massive abdominal tension can interact with the diaphragm and cause respiratory insufficiency. So you have to be careful with that as well. So this patient is not in overt distress. So you have the luxury of time of at least doing the exam and then getting the imaging and looking at the vital signs and so on. And POCUS is part of your physical examination as well. So you must maybe wondering, you want to look at the labs before doing the ultrasound, but it's part and parcel of the exam. So going through the layers, I would look for things simply as like a rectus sheath hematoma. No discoloration over the skin if there was a hematoma, if there was bruising that could indicate something that's bubbling under the surface. And then under that, look if there's any, look at the organs, any uterine, colonic, other I guess bladder, other organs that are in that area. Look for a distended bladder as well. And basically that's it. So look at those organs, uterus, bladder, and then the colon. And then there could be other causes of masses. May have to look at the reproductive organs, ovary, and also if there's lymph nodes and possibly other associated organs as well that you may want to look at. So I think the next step, Austin, you'll show us an ultrasound and we'll see what we can make of it.
All right, great. Yeah, awesome discussion. So, I consider myself a novice at POCUS, and I certainly have more skills and expertise now than I did, a couple of years ago when this happened. But I'll show you kind of what some of the things that I did in the moment. I might have done things a little bit differently now, but this is what I had done. So, the first thing I looked at was her kidneys. These are kind of representative images, and so I don't know if either one of you want to just comment grossly on what you see, or I can go through all of them and you can comment afterwards, whatever you prefer.
Samy, are you able to interpret the kidneys?
Yeah, so I think this is the right and the left kidney. So you always check in both planes, like horizontal and longitudinal, and on the left side doesn't seem, you always check, are there signs of hydronephrosis? Is like are there like dilatations? Is there like more hypoechogenicity as you would expect? I don't see that in both images here. Then you also can always measure like the size. Is it too big or too small? I don't know if that's accurate, Austin, that the left side is 13 and the right side is 11, or are both normally sized? But
both are normal sized.
Okay, thank you. And then you can also check what's like the ratio of the parenchyma to the medulla, and then get a ratio out of that. And for example, if you have CKD, a lot of glomeruli atrophy, and therefore your cortex will get less, and so the ratio will change. But otherwise, I would think that those two images are seemingly normal to me. I don't know, Ravi.
Oh, great start there, Samy. I'm impressed that it's a wonderful walkthrough of these images. I think just to add to your wonderful discussion, I think I'm also see that hyperechoic signal within the kidney there. So that's the fat that's in the calyceal region. I think it's intact there. So when you do see that, that's a healthy kidney. Once you go or develop medical renal disease, CKD, that tends to dissipate. So that signal will not be present there. And then going through the different findings of hydronephrosis, like you mentioned there, you're looking for bear claw sign. You're seeing this anechoic areas within the calyceal system that could indicate hydronephrosis, and also then thinning of the cortex, that sort of isoechoic structure around that superior around the calyceal system there. So this to me looks intact and normal. Is that what the finding was, Austin? Is there anything else that you were seeing? We're not seeing any other mass or anything there.
Yeah, no tricks. This is yeah, generally grossly normal, like right upper quadrant, left upper quadrant views, which is what I was trying to pass along. So you guys nailed it. So on to the next area that I looked at, which was her bladder and her pelvis area. So what do you guys think of this?
You want me to start again?
Samy,
Ravi?
yeah, go ahead. You're doing a
Okay.
great job.
Austin, could you maybe go back one slide to the kidneys? I just wanted to make another teaching point that could be important. On the left picture, you see the liver and the kidney, and the room in between there is called Morrison's pouch. And if you are suspicious for like free fluid in the abdomen, you should always check also the tip of the liver and the space in between those, because if you have free fluid, you could see it first there. That's one of the places you could see it. And on the right side, you also see the kidney, and above it, you see the spleen. Now you will see it. And this space in between that is called collar pouch. And there you can also see free fluid if the patient is having intra-abdominal free fluid. So this patient doesn't seem to have any abdominal free fluid in these anatomical spaces. That's just something I wanted to mention. Yeah, and on these pictures, that's like suprapubic, so we check for the bladder, and yeah, you can also measure how much urine is there. There are certain cutoffs that I don't know, post void, and yeah, and you can also check the space behind the bladder if there's also free fluid. That's called the Douglas pouch, and if you're a woman, it's like, I think, I don't know if I'm saying that wrong, but it's definitely behind the bladder, and that's called Douglas pouch. And there you could also see free fluid if patient is having, for example, ectopic urinary ectopic pregnancy or an intestinal bleeding, stuff like that. Yeah, but I would say that also this suprapubic sonography seems normal, maybe a little bit increased urine in the bladder, but that's all I can make out of it. I don't know. I would definitely ask Ravi for help.
Oh, you're doing a phenomenal job there. I think just knowing your anatomy, knowing how the image is, or how to orient yourself to the image, I think you're doing a wonderful job. So as you correctly mentioned, you're within the domain of the bladder. It does seem to be a little bit more exaggerated than normal. So it's got an anechoic signature within the bladder, which is likely the urine. And but what concerns me is you see this, it's not your usual topographic sort of circular configuration. You're seeing part of the wall is sort of indented by this structure. You're seeing distally there right now. You see that coming out. And then you have to sort of work through like what kind of organs could be in that area that could be indenting into the bladder there. So that could be any number of things. I mean, something that might come to mind is it's got a little hyperechoic signal there. Could this be stone maybe? So stone could be maybe causing this, maybe obstruction. Also have to wonder, I'm not too sure, but what other structures could be there? Could this be the uterus, or could this be part of the bowel wall as well? So something definitely I'm curious about that's indenting into the wall of the bladder. And then the next question would be, what is it? So this definitely raises a concern, and this needs additional imaging, which you need to support this with likely a CT scan of the pelvis and abdomen. Back to you, Austin.
Okay, very nice. Yeah, so I think this is some good teaching, and this was taken from the POCUS Atlas, which is a great resource. If anyone doesn't know about that, I recommend checking out their website. They also have an app that's free that you can download. But this is actually, it's supposed to represent a normal female pelvis with full bladder. So this is the bladder here. You can see sort of the outside of the bladder wall. Let it cycle through again. But this structure here is actually the uterus, and then she has an anteverted uterus. So when it goes through the top here, you can start to see what I believe is the top of the uterus here and the bottom there, and then you'll see the endometrial stripe that comes through when we cycle it. So right there. And so I think that's what we're viewing. But this was actually considered a normal pelvis, female pelvis, and that's what I saw in the moment. So now, this is the reason I don't have images is because I was so distracted, and like Samy, it's like, wow, I just want to point and shoot about what's happening, abdomen here. So it was a Friday afternoon in clinic, and so as these cases always are, and so I pointed and shot, and this is what I saw when I put it over the mass.
Okay, interesting. So all of the black, when something is black with ultrasound, you call it hypoechoic, and if it's like more white, it's like hyperechoic. And whenever you see black stuff on the ultrasound, you should think about fluids. And now, if you put it above that above that structure in the right or middle lower abdomen, it's most likely seems to me like some sort of local fluid accumulation. And type 1 thinking, if you see fluid next to the paracolic gutter, for example, you should think about ascites. So I would maybe also check other spaces in the abdomen. Does there also seem to be ascites? We checked the Morrison pouch, and there was no ascites. We had no signs of liver cirrhosis. So why should this patient be having ascites? The most common cause is portal hypertension due to cirrhosis. There could be still other causes for generalized ascites, or maybe is there something more localized, more local, for example, an empyema, an abscess arising from like an inflamed appendix, for example, or like GYN, some gynecological structure that got inflamed and is now building up a local accumulation of fluid. Otherwise, I can't really make too much out of that. Maybe the hyperechoic zones, you could think about like pus, that's also accumulating there. And it also seems loculated. It's like, if I always think about that with pleural empyema, when you think about these loculations in the pleural fluid, it somehow has a similar appearance here to me, but that's all I can get out of it. I don't know, Ravi, what do you think?
Again, Samy, a wonderful discussion, because we're sort of at the limit of our POCUS knowledge here. And I think what's helpful is when you have the probe, when you know where the probe is and where the image is being acquired, then you can, in your mind, then reflexively come up with like a list of potential organs that could be involved here. So I guess when putting the probe, is it to the left of the center, to the right of center, like where exactly are we acquiring this image? But just looking at this image, I think also Dr. Dancel is in the chat as well and has mentioned a couple of things. I'll ask her in a minute if she can also mute her mic and share with us some thoughts. But I absolutely agree, there is some anechoic space there. So this could be it could be water, it could be pus, could be blood. But those two that I mentioned, pus and blood, usually may have some cellular material in there, so it may have more of a colloidal feature, which we're not seeing here. But then we're seeing a lot of this isoechoic accompanying structure, which could be potentially like septae. And again, it's not a usual I guess a image that you get like with an empyema that you could see. So Austin's mentioned to the right of center longitudinal. Okay, the indicator towards the patient head. So the ultrasound device will have a little indicator, and that orients where you're going to obtain where you're going to have the image. And you see here the blue dot, the B is to the right there, and sorry, to the left of us, and that is in the mode to acquire abdominal images. And so something is like a cyst. I think Dr. Dance also mentioned cystic structure. And where could you have a cyst? Could the cyst be coming from the kidney? The kidneys were normal. Could it be coming from the bladder? I don't see a connection, but to the top there, I think it is the bladder. So a cystic structure from the bladder. Could it be and a uterine cyst? Could it be an ovarian cyst? So it could be a number of things. So our hypothesis generation is to that domain or that area anatomically, which requires further imaging like a CT scan to confirm this. But Ria, are you in a space to unmute your mic and maybe share some teaching points?
I love the teaching points about anechoic areas are fluid. Simple ascites generally isn't rounded. That's a kind of a key point. And most of these black spaces they look like they're circular or elliptoid. So I would say if this is ascites, it's loculated ascites. But I am also seeing more solid looking, especially on the left side of the screen, more solid looking areas. And so I am leaning towards this is more cystic structures within something that is solid. It's also large. This is 14 centimeters deep. So in a woman who's had a history or family history of ovarian cancers, and we're to the right of midline, and we're seeing something that is both cystic within maybe a solid structure. I'm thinking mostly worried about the ovary on that side. And then I was also trying to squint my eyes to see if there was any air bubbles in there kind of floating around, because an obstruction would also kind of look like this, but you would see peristalsis or attempt at peristalsis, and you would see air bubbles moving, but I'm not seeing that here. So I do think that this is cystic structures within a solid mass.
Well, thank you, Dr. Dansel, and for the audience, I just appreciate you so much joining us and also giving some teaching. And for the audience, if you don't know, Dr. Dansel is a nationally known teacher for point-of-care ultrasound and also a proceduralist, med peds hospitalist at the University of North Carolina. So really appreciate you logging on, also helping us with this difficult image. Back to you, Austin.
All right, sorry, I lost my mute button for a second. Okay, well, yeah, excellent discussion. And to Dr. Dansel's point, there was no appreciable air bubbles or peristalsis that I could see, but great, excellent question. So, as I said, this was a, oh, why isn't it working here? There we go. This was a Friday afternoon in clinic. And so I tried to make a decision about what to do, but obviously we knew there was something wrong. The patient wasn't doing well. So just given the availability of resources, I sent her to the emergency room to kind of get an expedited evaluation. So we have some blood work here. And so her initial studies here, I kind of highlighted the ones in bold, but I'll kind of summarize to say that she had a normal basic metabolic panel. Her lipase was normal. Her liver test showed a mildly elevated alk phos, but were otherwise normal. She had a UA, which had some wipes and one RBC, but no bacteria or nitrites. Her CBC was normal. She had an LDH that was slightly elevated, and she had multiple tumor markers checked. But the one that was most interesting was a CA-125 that was elevated at 4,000, with the normal being around less than 35. And then I have imaging. Would you like me to go to that, or you want to discuss the labs here?
I think this is interesting to stop for a second and just ponder over this CA-125. What do you think, Samy? This may be needle moving, but we have to be also very careful. But please share your thoughts, and I'll tell you what I'm thinking.
Yeah, thank you for pointing all the pertinent findings, Austin. That simplifies a lot. So pertinent positives seem to be like this very elevated CA-125, the LDH, the alk phos, and the UA. Maybe regarding the alk phos, I don't know what to make out of it at the moment. I'm always thinking bone, or is there some liver pathology? I would point it, maybe it points to metastasis or something else, but I wouldn't pay too much attention to it right now in the setting of this elevated CA-125, because that's like a tumor marker. I know that it's like one of the markers for ovarian cancer, and also with this family history. And as Dr. Dansel mentioned, that especially with this family history, we should definitely be cautious and think about also ovarian cancer. But I know that there can be a lot of false positives in other diseases that I do not know right now, or I should have to think a lot longer to like that some come to mind. Otherwise, the elevated LDH, I always think about cell death. Are there red blood cells dying, white blood cells dying, other tumor cells dying? You can sometimes get an elevated LDH with infarcts to the spleen, to the kidneys. And another thing that I'm always thinking about is PJP notoriously causes an elevated LDH. Won't be at play here, but just for the sake of mentioning it. And otherwise, the UA, we have small blood 1 RBC, large leukocyte esterase, 13 white blood cells. So we should always, when we get a UA, always ask, is the patient having symptoms regarding urinary tract infections, kidney stones, and really only interpret it in this setting, because you will get a lot of false positives, and overtreatment with antibiotics happens a lot also in Europe. So yeah, that's all I have. Ravi, what do you think?
Wow, Samy, you're an encyclopedia of knowledge there. Yeah, I probably don't even have to be on this VMR. You can handle this alone. And yeah, I'm very happy to hear that you mentioned like you have to be very careful with the CA-125 because it could send you on a wild goose chase. And what I've learned is not to use this to diagnose the patient, but you do use it to follow the patient in response to therapy. So, but then you can't avoid this elevated number. Yes, the outfos is minimally elevated. The LDH is also elevated, and there are some clues that something may be going on here. The UA is abnormal, definitely. Is normal. And the CA-125, what I started to think about, you mentioned a couple of thoughts there. So definitely the ovary. When Austin acquired the image, it was to the side of the midline, and as Dr. Dansel mentioned, the ovaries in that area. So definitely ovarian carcinoma. So usually you think of 5 things: ovarian carcinoma. It could there be adenocarcinoma, possibly of the cervix, endometrial carcinoma, and then you also start thinking about gastrointestinal tumors as well. So possibly 4 things. It can also be elevated in breast cancer. But this could be a false flag as well. You can have intraperitoneal irritation, and that could also cause CA-125 to be elevated. And as the case, Ravi and Reza had a case back in 2019 at SDIM, where I did learn this from. It was a case of intraperitoneal tuberculosis or tuberculoma causing a high CA-125, and everybody in the room was pretty much thinking this has to be a ovarian carcinoma. So back to you, Austin.
All right. Yes. So very nice. So finally some formal imaging that everyone's been waiting for. But this was her CT scan. And so this is kind of the final aliquot for the diagnosis. So if you guys want to put your nickel down, you can, and can kind of go through the interpretation and the results after you guys discuss.
I'll just note one thing, because everybody's looking at the mass, but I do see a lot. There's quite a bit of stool, or the burden of stool is moderate in the bowels. So there is some constipation as well, in which you did highlight in the review systems. Now, getting to the mass itself, what do you think, Samy?
Yeah, it seems cystic to me in the lower abdomen, and yeah, I really don't know what that is. I would definitely go down and talk to a radiologist about it and ask what they think, or read what they wrote. But yeah, this is, for me personally, it's suspicious for cancer. But definitely we have to be very certain of that, to then also express that to the patient. So yeah, that would be my main diagnosis.
What's really interesting in that middle image there, you do see it abutting the bladder and indenting into the wall of the bladder. So that was exactly the great image that Austin gave us there. We're seeing that now on the CT scan. So yeah, very concerning, and definitely warrants more intervention, and possibly surgical exploration, surgical oncology, and also oncology on board. Back to you, Austin.
All right. Yeah. So very nice discussion. And so, the final read of the CT was a large 15 centimeter complex multilobulated cystic mass, which partially encases the uterus and seems to originate from the right ovary. There was just a small amount of ascites, and then they had noticed her reticulation and nodularity of the omentum in the right colonic mesentery. So of course, she was seen by a gyne-onc. She underwent a total abdominal hysterectomy with bilateral salpingo-oophorectomy. I can't believe I was able to say that. And so it determined that she had a high-grade serous carcinoma of the right ovary. Fortunately, it was limited at that time, so the surgery didn't show any evidence of lymph node involvement or any evidence of disease like outside of the tube itself. So she got surgery, and then she was started on chemo with carboplatin and paclitaxel, and had a really nice response. So this is pretty early on in my practice, like using POCUS in my clinic by myself and just trying to learn more and do things. And sometimes pointing and shooting, you never know what you're going to find. You just have to be careful on how you interpret it. But at this time, this is my note. This is how I interpreted it, because I honestly had no idea what was going on. I knew that the patient needed more evaluation, but I didn't have the confidence or the expertise to interpret definitively what the ultrasound was. And that's one of the beauties of POCUS. You don't necessarily have to know everything, but if you know your limitations and you apply them appropriately, then really it's a tool just to augment. Like we use physical exam maneuvers, we use labs, we use history, like all of those things are diagnostic tools, and POCUS can be the same, but all those things are limited by user experience and everything else as well. So I wrote, hey, this is concerning. I'm a novice, but I thought, could this be a bowel obstruction? Could this be constipation? Could there be adhesions, or could it be ovarian pathology? But as you can see, I didn't know. But I knew that she needed help, and we were able to get more expedited evaluation in the emergency room. And so my big reflections from this case were, don't be afraid to pick up the probe. Even novices can make important discoveries that impact care. Like, again, I didn't arrive at the diagnosis right there, but I had it in my differential diagnosis, and I knew that, hey, I don't think this can wait. In this particular case, it was pretty obvious. She had a palpable mass in her abdomen, but oftentimes it can be more subtle than this, but it can help you triage the patient when you're not working in the hospital setting. I had no labs, I had no anything. I just had my history in my exam and my ultrasound. That was it. And then I think as I've kind of grown more in ultrasound, and it's important to be systematic. I got very excited about this thing there, but if we step back and say, hey, could this just be a bladder that needs to be drained, like Dr. Denzel had mentioned? Could this be, hydronephrosis? Could this arise from the kidney or the liver? So being systematic in how you do your scans and not going just straight for the pathology is important, and that will also allow you to make sure that you're interpreting your studies correctly and that you're not sort of biased by what you see. And more information can be confusing, but it also can help you get clarity in the diagnosis. And then, the third sort of final reflection was genetic testing is imperfect. And so this case, I remember this patient vividly being worried about this for about a year before this she presented. And so we sent her to the geneticist, we figured all this out. But despite all this, she ended up having ovarian cancer. And she sort of asked me, why did this happen? And, I don't have a great answer for that. But I think just reminding ourselves that genetic testing is imperfect. You have these panels, they check large genes. Some of them check many different types of cancer genes, but they don't test the whole genome. And there's many, many things that we don't understand. So, each test has limitations. And so I think it's just a reminder for a test that we don't necessarily order a lot, but genetic testing is imperfect as well. So those are my reflections.
Thank you, Austin. That's remarkable. I'm just amazed that you're integrating POCUS into your daily examination, and apparently that's how you learn. So there's the standard POCUS that you learn, and then there's things that you're not familiar with, but this is how you build your skills and your repertoire through various cases and your experience. So I really appreciate you bringing this case to us. I'm just going to have, before we do teaching points, Dr. Dancel has some images she could share with us just for a differential diagnosis to get a little bit more POCUS teaching in. So I'll, Austin, if you can stop share, and then Dr. Dancel can share a screen.
I think.
Oh, I think you're muted.
Okay, sorry. How about now? It's only been 4 years of Zoom, right? So we talked a little bit about our differential diagnosis for what we were seeing, and I wanted to show you some pretty classic examples of some of the things that we talked about. So I just pulled up for my own library. This is what ascites looks like. You can see that it's anechoic. I'm going to play it. And then what I was saying about simple ascites will have like these pointed areas where the fluid kind of abuts the intestines here. So if you see pointed areas, that's more going to tell me there's like some pointed areas in here between the bowel, tells me that this is a simple ascites. This is more of a loculated ascites in someone that had a tubal ovarian abscess that had seeded her peritoneum, and you can see all of these septations here. And then there are rounded areas. I don't know if you can, hopefully you can see my pointer, but on the bottom right part of the screen, you see some rounded areas here that have ascites. And this is loculated ascites, and so less rounded, but still ascites. This is more of a complex ascites. We talked about SBO, and this is a really good example of SBO. Again, we're seeing not really anechoic areas, but these are hypoechoic areas. And I was telling you, I was looking for bubbles. And if you look closely within this loop of bowel, you can see some attempt at peristalsis. Anyway, these bubbles don't really have anywhere to go, but they're moving around within these large dilated bowel loops. And these are also rounded, as you can tell. And then finally, this is a simple ovarian cyst. So when I play this right now, this person has ascites. I was asked to go do a paracentesis, and we were scanning around, making sure we had a very safe place to put our needle. And then we saw this big circular area here, and that's almost a perfectly rounded 10-centimeter simple ovarian cyst. You see how it doesn't have any solid areas in it? It's really just one large simple cyst. So this is something that I would ignore. It's not uncommon to see that, actually, even that large. But certainly the one that Austin showed us was very, very worrisome. And POCUS is all about pattern recognition. So once you start seeing these patterns, really what Austin said was absolutely correct. Just pick up your probe and you're going to at least be able to say, I've seen this pattern before, I know what it is, versus this looks abnormal to me. I don't really understand what this pattern is, so I need some help.
Absolutely remarkable. Thank you for sharing that with us. Definitely that will improve readership and image interpretation amongst our CPS audience. And I really appreciate you bringing teaching points for the POCUS images today. And we'll hand the mic over to Marino's doing teaching points. So if you could take it away. Thanks.
Sure. So let me take it in some precision and maybe because actually I like of how to talk in this presentation makes everything to the every time we have a sheet pain, the clinic needs to give us blood data and how to actually. There are many factors. Like, is it actually abdominal pain? For crime, we have to ask about the quality for the pain. Control or actually to call pain, and we should be focused when we patient with pain that already we need quite an hour to column and never we are present. The OBG. So
sorry, Marina, you're breaking up a little bit.
Wait, okay.
We cannot hear you.
Oh, sorry. What about now? Can you hear me right now?
Yeah, we can hear you now. Thanks.
Where did I stay? um,
I
We
think
lost you from the beginning.
oh, so I have like a really long time talking alone. So basically, I'm gonna start again. So basically, what I was telling is that when we get abdominal pain, the clinical history is going to give us a really big clue in how to tackle this shift complaint. So maybe we have to ask some questions about, is it actually abdominal pain? Is it acute or chronic? We have to ask about risk factors, precipitating factors, and alleviating factors, also about localization. In this patient that presented with intermittent pain, we need to worry about causes of colicky pain. So many causes of colicky pain in this case are spleen, gallstones, bowel obstruction, and nephrolithiasis. In this patient that presented with left-sided abdominal pain and with radiation to the back, we need to look in the history for, or widen our spectrum to look for spleen pathology, colon pathology, pancreas, and kidneys pathology. But also something really important that we tend to forget when examining patients is that many abdominal, many causes of abdominal pain in female patients are located in the pelvis or in the reproductive organs. So the OBGYN history is really important when we are examining a female patient with abdominal pain. Also, it was mentioned that the patient is from Latin America, and we always need to look for or raises our spectrum for abdominal pain, but for endemic causes. In this case, we need to think about tuberculosis and histoplasmosis. So I divided the teaching points between three main stigmas here. So the second one is ultrasound. We need to know that ultrasound is a quick and safe tool that can give us a lot of clues to a potential diagnosis and to rule out diagnosis, and if we are present in an emergency, so we can actively treat it. So some basic findings of US of ultrasound is that if we have hypoechoic, it means that it's dark and probably means fluid. When we get hyperechoic findings, it means solid. When Austin showed us the kidney ultrasound, it showed an hyperechoic part that means that it is fat. And when we have a chronic kidney disease patient, it actually dissipates. When we get hydronephrosis, the ultrasound is going to show a lot of more anechoic areas. The simple ascites, basically, when patients get ascites, we will have anechoic findings, and it is not rounded, as Dr. Dansel said. And also a pearl that Samy shared was that we need to check the area between the right kidney and the liver, and the area between the left kidney and spleen to look for intra-abdominal fluid. So those are areas that can have rapid accumulation of fluid, and we need to rule it out. And the best way to do it is with an ultrasound. And also a very interesting discussion was talked about the tumoral markers. So when we get tumoral markers, we shouldn't use them to diagnose the patient, but we should use it to follow up how the patient is responding to therapy. In the context of this patient, she also had an elevated LDH, and elevated LDH means increased cell turnover or increased anaerobic metabolism. In the context of this patient that she had an elevated LDH and an elevated tumoral marker without knowing if she had a malignancy or not, both of these findings together can give us a really big clue that we are present in a probable malignancy state. So that's what I have for you today, and thank you for your attention.
Wow, thank you so much, Marino, for these amazing teaching points. Thank you all so much for spending this amazing hour with us. It really was a pleasure, and thank you so much, Austin, for presenting the case, and also Dr. Dansel stepping in and giving us some extra teaching points today. So Yeah, Ravi, always a pleasure to discuss with you, and you all have a great day and enjoy. See you next time.